We are your hosts, Nikki Shore and Jesse Swain, and you are listening to the American Journal of Infection Control podcast, Science into Practice, brought to you by the Association for Professionals in Infection Control and Epidemiology to highlight work published in our peer-reviewed journal, ACHIC.
Join us as we speak to those in the field of infection prevention and control, like us, as well as other experts, to learn about some of the latest research in the field and how it can be put into practice. We hope you will listen in, learn something new, and apply this information to your work. If you are not a researcher already, we hope this podcast will get you thinking about areas where you can carry out your own research.
So, hey, Jess, it's been a few weeks since we've talked. How's it going?
Great. How about you?
I'm doing pretty well, thanks. Hey, I've got a question for you. Are you vaccinated?
Absolutely. I was so excited to be vaccinated.
Me too. Are you boosted?
Not yet, but I am planning on it.
What about your kids?
My kids just got their second vaccine last week, actually.
Fantastic. And what about your husband and your pets?
No, my husband was vaccinated actually before I was, but my pets?
Yeah. Have scientists figured out why cats catch COVID?
That's a great question, but I don't think they've had enough study participants yet.
Yeah, I think it's still a meowstery. Yeah, it wouldn't be, we haven't had one of our pandemic jokes in a while, so it wouldn't be a show without it. Okay. All right. That's going to lead us into our topic for this episode, where we're going to discuss the ACHIC article, COVID-19 Vaccination Hesitancy Among Healthcare Workers, Communication and Policymaking. And to discuss it with us today, we have Dr. Gina Piscitello, an assistant professor of palliative medicine, hospital medicine, and ethics consultant at Rush University Medical Center. Her research interests involve patient, family, and clinician communication, ethics education for medical trainees, health equity, and allocation of scarce medical resources. Welcome, Dr. Piscitello.
Hello. Thank you both for having me today.
We're pleased to have you. So this is obviously a very important topic in infection prevention, so I kind of want you to just kick us off by giving us a quick overview of your research and what prompted it.
Yeah, so first I want to give a shout out to the co-authors on this paper, Stephanie, Eric, and Rupali, who were great to work with. This was a true collaborative project across multiple hospitals and hospital systems. The intent of the project was to evaluate healthcare worker COVID-19 vaccine uptake and the reasons for why they are getting the vaccine or why they are choosing not to get the vaccine. And so the study used the health belief model to evaluate different factors encouraging uptake for some patients or potentially, for some healthcare workers, or potentially barriers to uptake. And that survey was created and then sent to hospitals in 3 different large medical systems in the Chicago area and surrounding areas. And so from that, we got some very interesting findings that I'm looking forward to talking with you about today.
Yeah, we're excited too.
Mm-hmm. So can you tell us a little more about the health belief model and how it was used in the study?
Yes. So the health belief model, it was created in the 1950s. And in health belief models, it's meant to help explain and predict health-related behaviors. So from that, we use that framework. The survey was actually created by 2 of the authors, Stephanie and Eric. And it used this model to look at healthcare workers, their perceived susceptibility to COVID-19, perceived severity of COVID-19, perceived benefits of the vaccination, perceived barriers to vaccination, and then looking at cues to actions. So cues to actions are like internal or external stimuli that might affect one's decision to be vaccinated or not to be vaccinated.
So can you tell us how significant an effect do you suspect that vaccine hesitancy in healthcare workers has on public hesitancy?
I am concerned that it does have quite an effect. You know, we do have quite a high uptake in healthcare workers of the COVID-19 vaccine. But healthcare workers are an extremely trusted profession throughout the U.S. There's data to show back from June of this year that about 70% of Americans trust their physician, 79% trust their nurse, 75% trust their pharmacist. So these are very highly trusted clinicians. And when some people in these areas are choosing not to be vaccinated, people trust them, and they're wondering, well, why are they choosing not to be vaccinated? Sure. And that's why it's important to know, especially, why are they choosing not to be vaccinated, and see if there's any ways that we could potentially help change that so they feel comfortable with vaccine.
Basically, if healthcare workers are hesitant and skeptical, why wouldn't the public be?
Right.
So, I thought it was very important, you note in the paper, that vaccine campaigns generally fail to address the healthcare worker vaccination concerns, which ultimately diminishes the utility of vaccination campaigns, since low or slow uptake among healthcare workers is more likely to inspire concern rather than trust in the vaccine among the public. And that really highlights, like you said, how influential healthcare professionals are on public opinion, and thus how important it is maybe to start your vaccine campaigns by educating healthcare professionals.
Yes. And I think in many ways this was done, but I think that kind of from what the data that we saw, we could do an even better job. So for one example, from our survey of all the hospitals that were surveyed, so it included Advocate Health System, Rush University Medical Center, and University of Illinois Health. 15% of the people who responded to our survey chose not to get vaccinated or are planning to never be vaccinated. And looking at that data, some of those people that chose not to be vaccinated, one of the reasons is they think that the data is not good enough. The data is not good enough to support vaccination. And I think many of us can agree, I don't think that's where we're at if you look at the data. And so I think, talking with my study co-authors as well, one way that we think that we could help improve this is, more education for all healthcare professionals, not just physicians, everyone throughout all of medical training. How do we, do an analysis of medical research? How do we personally evaluate the statistics ourselves? And how do we collaboratively discuss these matters? I know as a physician, there was a lot of access for me to be able to, listen to lectures and kind of go through like the New England Journal articles and see kind of like how these vaccines are working. But are these same opportunities available for other staff, like nursing staff, environmental services staff, staff throughout the whole hospital? And I think that's where we could expand kind of as a society and healthcare organizations across the country, that we had these discussions together, but in a way where people who, everyone feels comfortable kind of expressing their opinions as well. I think there's multiple avenues where would a nurse feel comfortable speaking up when it's a room full of doctors, talking about these matters? Like maybe we need to, provide these avenues where anyone truly feels welcome, kind of expressing their, opinions about the article, expressing their, inability to kind of understand certain parts of it, making sure that there's a safe place for them to discuss those matters as well.
So can you also tell us a little bit about the factors that were considered significant predictors of vaccination?
So looking at demographics of who chose to be vaccinated and who chose not to be vaccinated, the main demographic variables that were found to be statistically significant were that people who self-identified as Black were less likely to be vaccinated. People who self-identified as Republican or leaning toward Republican on the spectrum were more likely to be choose against vaccination. Or people who thought that they were allergic to any vaccine component, they were also less likely to receive it. So we looked at some demographic factors and some personal factors of the healthcare worker themselves. And then we also looked at other factors too, like perceived barriers, perceived benefits to the vaccine. And those were kind of some really interesting measures that we found as well.
That's really interesting. Can you talk a little about the social cues that encourage some healthcare workers to vaccinate?
Yes. So I think one of the most interesting parts of the paper is that these cues to action, kind of what helps encourage people internally or externally to be vaccinated. They were something that I was kind of surprised by when we got the results in the end. I guess I kind of assumed that the mass media would play some role in people's intent to be vaccinated. When we looked at this, though, we were comparing the odds ratio of people who chose to be vaccinated against people who chose not to be vaccinated. The odds ratio for that was only 1.83 for the media to help kind of positively influence you to be vaccinated. But then when we look at measures like that people close to you think that it's important to be vaccinated, that odds ratio was 18.9. So people who are close to you, people who are your colleagues, your personal clinician, those are the people who are kind of helping to encourage you to be vaccinated. The media really doesn't play much of a role. And then we also looked at the likelihood that like a supervisor, does that help encourage you to be vaccinated if they are encouraging you to be vaccinated? The odds ratio on that one was 5.52. So your personal close like friends and close colleagues, those are the people who are most likely to encourage people to get vaccinated. Those are the people that we should be going after to try to help encourage vaccine uptake. Supervisors, they're playing a role, but less so than colleagues and close friends. And the media is playing a much lower role, at least from this data that we found.
That's really interesting. And I know in my own personal experience, I've seen families that had, some people that were vaccinated and some people that weren't. And in addition to that, even amongst some healthcare workers' families where the healthcare workers are vaccinated, but they, as much as they've tried to encourage and reassure about vaccines, they have gotten almost no success in getting some of their family members to change their minds. So I think it's really interesting, that particular thing.
I was a little surprised by that too. I would have thought that external stimuli like media would have had a much heavier role in helping people decide whether or not to get vaccinated, just from, again, my personal experience and seeing what was going on social media. But it also, again, it highlights the importance of healthcare workers' influence and, the decision to vaccinate being highly influenced by what their colleagues think. So you mentioned in the paper how important it is to foster relationships and trust building with employees across departments and job roles, especially among nurses and physicians who are highly trusted. And you also mentioned, I want to bring this up, creating safe spaces so workers can express their questions and concern, being open and transparent about it. And there is an inherent power structure and hierarchy that sometimes serves as a barrier and intimidates workers. People don't want to bring forth questions and skepticisms, not knowing how that's going to be perceived and received, right?
Right. And I think that power differential, I think people do such a great job. And truly, I saw many great examples of people reaching out to the whole staff, talking about these matters. But that inherent power structure, I think it's very important that we acknowledge it exists, because there's some people who are never going to feel comfortable in these big, 1,000-person settings where we're talking about these topics. They're never going to feel comfortable speaking up to ask a question. And we just must have some other avenues as well. So maybe small group settings where they can ask these questions and not be worried that maybe their job's going to be held against them if they seem like they might be against vaccination in any way.
Right. Like maybe having an infectious disease physician come talk to each department singularly during a staff meeting or something, or, lots of ideas. Do you have any idea of what percentage of healthcare workers who were vaccine hesitant that changed their minds?
That is a great study question, and we don't. And I think one limitation of our paper is that this was done kind of between January and March of 2021. So I'm hoping that, maybe a lot more people have changed their mind about things, where the data was at the time. So some of the matters here. So we looked at the perceived benefits of getting COVID-19 vaccine, and we found that people who got the vaccine, they think that they are much less likely to infect patients if they get the vaccine. They're less likely to infect family members. The odd ratios on those were 22, 27. The reason I'm bringing those up is that because back in that time period, I kind of wonder maybe that data wasn't strong enough. Whereas now if we repeated that data, maybe these odd ratios would not be as high, because maybe there's more of the population of healthcare workers who now believe, I get this vaccine, I'm less likely to give it to a patient or family member. And that might be one reason why I choose to get the vaccine.
And to piggyback on that, we were wondering if you have any data on what percentage of those healthcare workers were or intended to be vaccinated that had also cared for COVID patients.
Yes, and that is a great study question. We did not do that, and looking back, we absolutely should have. The one thing that we did assess was healthcare workers that worked remotely. Was there a difference between them getting the vaccine versus not? And we really didn't find a statistical difference with that. But absolutely, I would assume that people who are working frontline with COVID patients would be more likely to uptake it. But from our data, we didn't have it. We didn't evaluate that.
Yeah, that's a really interesting question. Another question that comes to mind is, was there a difference noted between regional locations, so particular parts of the country, or rural versus more metropolitan areas?
Or state by state, even down to county levels?
Yes. And I think that is so important. What we did assess for was the home neighborhood of the person responding to the survey. So I should tell you, so Rush University and University of Illinois Health, they are located in Chicago. Advocate Health Systems are located surrounding Chicago and then kind of in surrounding states as well. So we did have a population that was rural based, living in rural areas or suburban or city based. And so we asked those questions. Do you live in an urban area, suburban area, or rural? And what we did find was that there was a statistical difference compared to comparing where you live and how likely you are to get the vaccine. We found from the healthcare workers that responded to our survey that people living in urban areas were statistically more likely to receive the vaccine than people living in rural areas.
That's really interesting. I know that I have heard the comments like, oh, I never see people, but it's not like these people are isolated in their homes. They're still, they have to go out and do shopping or they have children in school. And so it's really interesting to me what people's perspectives are around where they live and their interactions with the community. And that their reason for not getting vaccinated is that they feel that their interactions are so low that they wouldn't necessarily either contract COVID or be someone who would transmit it to others in the community.
Yes. And I think, with this article that we did it, earlier in 2021, well, who was being kind of predominantly affected by COVID at that time? It was still people like living in these urban settings. I wonder if we were to repeat the data now where people more in rural areas are getting affected by COVID, whether that data might be a little bit different. I think one of the main complications of this, and I think you guys both kind of addressed this, the people who actually can see what COVID looks like, especially seeing what COVID looks like at the end of life. I think for me as a palliative care doctor, seeing these people, like some of them suffocate to death.
Oh, yeah.
Like if you see that, like how can you not get the vaccine? I think that's just such a factor in this. And I think with these strict visitor restrictions that we had, I think that's a huge factor. Like people couldn't see it. There are people who don't believe that this is actually happening, that these people are in the hospital. And I think part of it's because we're not letting them come and see their loved ones. Things are getting a little bit better with visitor restrictions, but just like that trust, like there's a fundamental lack of trust. Some people just think that we're lying. And I think that's something that we need to like fundamentally address. And, is that, bringing these people into the hospital so they can see what's going on, so they can see it for themselves. I think that's going to be always hard to do. Patient privacy must be protected as well. But I think there's some fundamental failure. People truly, they don't believe it's accurate.
Absolutely.
We have to do something.
Yeah, I think it's super scary. And I think what would also be interesting to look at would be whether the healthcare workers that are vaccinated are also vaccinating their children, or whether, they have hesitancy because they're children. So that's another thing that I'm interested in seeing in the future.
Yes, absolutely. And we did assess for that in our study as well. If you have regular contact with children, were you more likely to be vaccinated? We also looked at that for like elders. If you're more likely to like work with elders, are you more likely to be vaccinated? It was more like the family members. If you have a family member with chronic illness, that kind of encouraged you to get vaccinated. So it's kind of interesting. I think I just kind of assumed if you lived with like an elder, like parent, like that would also encourage you to be vaccinated. But statistically, that was not so.
It's interesting.
So what do you think, Dr. Piscitello, what could we have done in the beginning? What could we have done differently to increase vaccine confidence?
I think the main thing, there were so many things done right. I think one of the main things would be just to get that, like the data and the literature out to the healthcare workers in ways that they can like truly go through all of it. That they can like look at these journal articles and go through it with them, kind of, piece by piece, what is this data showing here? Look at the medical complications of the vaccine, how unlikely are those to occur, and make sure that they're able to go through those. I just think like the outreach in that way to truly like take that data in a way where they can like ask any question in a way that they're comfortable asking it. I wish that we could have done that a little bit better.
Yeah, I think that was a really important takeaway from the article, is just saying, we need to reach out to healthcare workers to make sure everybody understands the science behind it and has safe space to ask questions and air their concerns. But thank you also for mentioning the things that went well, because there are a lot of things that went well with it, and we've got some growth. We learned some opportunities from it.
And what do you think that we could do now to help encourage vaccination and reduce some of the ongoing hesitancy?
Yes. with that, I think just hearing the people where they're at in a way where they don't feel like their job's on the line for it, I really do worry with these vaccine mandates. I think they were, for patient protection. I think these vaccine mandates, I totally understand where people are coming from, but I just worry how many people are out there like fearful of their job because of this. How much like moral distress or moral injury has that cost these healthcare workers that they're dealing with, all these other factors during this pandemic in addition to this. And just like, is there a way, like, how do we reach out to them to make sure that, they're doing okay, like their mental health is doing okay? I worry that we did, potentially force people to do things against their conscience. And like, what is that going to have downstream? Are they going to hold like, resentment against their institution, like for a long period, or like, against like the state or, country, like for federal mandates? Are they going to hold this resentment that's going to affect us long, long down the road, not just about COVID-19 vaccines, but about other matters as well? That's really going to lead to us, more fracturing of a society where we really need to bring it together.
Yeah. And, something else I didn't think about till you just mentioned that is, I guess there could be a sentiment in the public where, if we're making these healthcare workers do this, how safe and effective is it if we're making people do it and they aren't doing it on their own free will?
Yes. And I think, when we put out these vaccines, I think it was very, that the choice was made to vaccinate healthcare workers first before anyone else in America. I think it was a very, interesting decision that was made. And I think, because people thought like, well, healthcare workers are such a trustworthy body. They are putting themselves at risk of COVID by caring for these patients. But, we're healthcare workers, like, were they the highest at risk? Some healthcare workers were high risk, based on like their own personal factors. But, we knew as a society, there were other patients out there. Some of our patients were much higher risk than ourselves were of like dying from COVID-19. And I think, the choice was made to vaccinate healthcare workers first because of that trust factor. And because like to help kind of repay, we healthcare workers, at the beginning, people thought they were putting their lives on the line, especially if they didn't have adequate PPE, they were. So by, vaccinating this trustworthy group first, and hopefully other people will trust us. And that was, part of the intent with it too. I think that intent was great, but, and especially at the beginning, we saw such significant like racial divides in those healthcare workers who was actually receiving it and who wasn't. And I think it's not just the healthcare factor piece; it's the like collegiality of it. That's what we should have been focusing on. Is not just like those healthcare workers that are trustworthy. It's that like we as a group of healthcare workers must be talking about this issue together. You can't just trust us to get it. Just say like, oh, assume we have the data, we're going to do it. We need to go out to all healthcare workers and not just like the big academic centers, which I think academic centers, did a great job at this. But what about all those nursing home workers? Like what organizational structures do they have to learn about the COVID-19 vaccine and talk about it with others?
So do you think we just didn't expect healthcare workers to be so hesitant?
I think that's definitely part of it. And I think people also assume, I remember like the very initial, like when the vaccines were distributed, it was very like a lot of white people were getting the vaccine of the healthcare workers. And people are just assuming, well, doctors are white. That's like the reason why they're getting it. Well, if you look at healthcare workers, they are an extremely diverse group of people of all races. And I think like we just kind of, it's maybe this like an ingrained bias in us. We just kind of assume like, oh, this is what doctors and nurses look like. They are just going to take the vaccine because they look like us. We talk together. This is what it is. Where really the healthcare worker like workforce is a lot more diverse than I think maybe what it's like kind of assumed to be and what like the public views it as. And I think like that diversity, that's something that we maybe could have done a little bit better on, is like seeing these diverse viewpoints. How do we best approach all these healthcare workers instead of just the ones that we kind of, stereotypically assume our healthcare workers?
Yeah, I think that makes a lot of sense. And I know that we have had in our state a lot of outreach programs to ensure that we're getting, the diverse populations and even, other populations like the elderly populations that are homebound or, don't have a way to get transportation to a vaccine clinic. So all really great points. And one thing I will say is that when, we had our vaccine clinics in our hospital, it was amazing to just feel the happiness radiating from people as they lined up to get their vaccines, and like this feeling of hope, that we were actually moving forward in some ways. So hopefully we can spread that to the rest of the people that have this hesitancy and get them feeling more comfortable and confident in the efficacy of the vaccines, and continue to move forward as a united front, a united country. But do you have any particular takeaways for our audience today?
Yes, I think the main takeaways are, I think a great job was done. People really did work together to help, reach out to healthcare workers and give them the data about vaccines. And, I think the media too, Dr. Fauci, I think he did a great job reaching out to the community. With that being said, we still have a ways to go. This data was showing us 15% of healthcare workers did not get the vaccine and were not planning to receive a vaccine. This data is some months old now, so hopefully there are a lot more healthcare workers that have received the vaccine. But I think what our purpose should be right now is that we have these specific groups. We have this data. Certain groups were not getting vaccinated as much. Those are the groups we should be reaching out to, making sure that they have people that they trust. Those are the people that should be, reaching out to them. That's what we should be working to foster. I think these cues to action that we found in the paper, we know how we should be doing it now. And I think it's just maybe that we have this data. That's what we should be really focusing on moving forward, because we still have a way to go. I do wonder with the hospital mandates, you see it in the news that, people are still kind of, healthcare workers are pushing back against these mandates too, for religious exemptions or other purposes like that. And you wonder kind of internally with these hospitals, how many of these hospitals have workers currently working that are not vaccinated? A lot of that data is not public. So it would be really interesting, I think, for future research to see how many of those people are not vaccinated and kind of reevaluate where are we at now, what kind of cues to action to those people where we're at now, what do they need to help encourage vaccination?
Absolutely. So thank you so much for joining us today. This was a very interesting study. We really appreciate your work and your advisement going forward to help decrease this hesitancy and get more of the population vaccinated and create more trust in our entire population out there.
Well, thank you for joining us today. We are Nikki Shore and Jesse Swain, and this is the American Journal of Infection Control podcast, Science into Practice. Thanks for listening and doing your part to prevent infection, because remember, infection prevention is everybody's business. To hear other AGIC podcast episodes and to access information about this podcast in the field of infection prevention and control, go to our website at agicscienceintopractice.org. That's AGIC, scienceintopractice.org.
AGIC Science into Practice is created by the Association for Professionals in Infection Control and Epidemiology with input from the APIC Research Committee and Pat Stone and Jean Brandt at AGIC and APIC staff, Lisa Tomlinson, Liz Garman, Bobby Golshin, Chris Ruiz, Kelly Lynn Russell, Sylvia Quevedo, Kaylee Deaton, and Christine Miller. We work in partnership with Human Factor and audio tech Blake Alton.